Awesome. Good morning, good afternoon, good evening from wherever you happen to be joining us from. Thank you so much for choosing to spend your time with us today. We have an incredible lineup of speakers who are some of the most forward-thinking leaders in health misinformation right now, with experience that crosses academic research and running health misinformation response efforts and developing new approaches for fact-checking health content. Before I introduce our speakers and myself, I wanted to prepare you all for what we're going to be discussing during this panel. So we'll cover some important topics for effective preparedness and response to health misinformation challenges. We'll specifically talk about stigma. We'll talk about what to do in the spaces between verified information as it emerges. We'll talk about staying effective in our approaches, and we'll talk about strong collaboration. Thank you again for joining us, and I'm excited to introduce our panelists soon. As we address stigma, I wanted you to know and to keep in mind that the ways in which our unique roles as responders to health myths and questions about health beliefs that we hear and that emerge requires us to do our part to reduce the stigmatization of information seeking around these topics. We'll also make sure that we discuss fact-checking in sort of the spaces in between empirically validated or replicated scientific information. So my brilliant colleague at Meedan, Xiaomina, distilled this challenge of how to fact-check the spaces between empirically validated content, especially in light of the challenging COVID-19 information ecosystem right now as addressing misinformation or misunderstandings and confusion based on emerging evidence, often related to emerging scientific knowledge or research with insufficient sample sizes. And we'll touch on how this relates to the emergence of conspiracy theories and the role that misinformation plays, as Dr. Amobi's research shows, when populations seek to return to the status quo during times of crisis. We'll discuss how to stay effective, sharing the latest scientific research that Dora-Olivia Vicol from Full Fact is putting together. And we'll discuss some of the importance of strong collaboration. So different models for working with subject matter experts to mitigate some of the challenges that relate to public health information response efforts. There will be time at the end for questions, so please do share them on Slack or on YouTube. And we do also want you to know that some of our slides do contain quite a bit of content, and we'll be sharing them with you, as well as links to the projects that we reference in this talk, so you can get more information if you're interested in collaborating. Okay, and now we can introduce ourselves. So again, as I kind of mentioned in the beginning, it's important for this field to start grounding this presentation in the reduction of stigma. We know that as researchers and as practitioners in the field of health misinformation and misinformation response, this field tends to carry a lot of stigma with, reactions to what can be perceived as outlandish health misinformation claims that can lead to consequential health outcomes. But it's a bit of a difficult balancing act to reduce these negative impacts of health misinformation and problematic beliefs, and then to ensure that we maintain a safe space for asking questions about these topics. So let's start by leveling the playing field. I'll introduce myself, and we'll go down the line with Dora-Olivia Vicol, Dr. Theresa Ifeaoma Amobi, Syed, Nazakat, and Eric Mugendi, all of us sharing a health myth that we ourselves carry with us, even as scientists and fact checkers. So I'll start here. I'm Nat Geynes. Thank you so much for being with us. I'm the director of Meedan's Digital Health Lab. I'm a public health researcher by training, and the health myth that I carry with me was taught by my mother when I was growing up, that I shouldn't touch my nose because if I do, it'll grow. And I still have anxiety around touching my nose. So let's follow up with Olivia, and then Dr. Amobi, and then Syed, and then Eric.
Hi, everyone. Thank you so much for having me. That's a fantastic intro, Nat. My name is Olivia. I'm an anthropologist by training. For the past 10 months or so, I've had the great privilege of working as a researcher for Full Fact. And the myth I carry with me, also passed on by my mum and family, is that scratches, wounds, and cuts can all be treated with a bee-derived component called propolis. it's an ointment and it just works like magic. That's my myth.
Awesome. Dr. Amobi.
Hi, everyone. Great to be with you. The myth that I carry around with me is that when you hit your right toe against a stone, it means that something bad, something good is going to happen. But if you hit your left toe, then something bad is going to happen to you.
Middle of the road news for the clumsy ones of us in the room, for sure. Syed, what's your health myth that you carry with you?
Hi, everyone. I think really glad to be part of this very important conversation. I think I'm Syed. I'm based in New Delhi, in India, and I'm the founder of DataLEADS, and we run one of the platforms completely dedicated on fact-checking medical misinformation. I think one of the myths we have grown up with is essentially don't eat fish with milk because it's not safe for your skin or it's not safe for your tummy. And I think everybody almost believed it, despite knowing that this is no scientific evidence for that.
Awesome. And Eric?
Cool. Good evening from Nairobi. My name is Eric Mugendi. Hi, Nat. Thanks for hosting this. And I'm the managing editor of Pesa, which is a fact-checking initiative based in Nairobi. And we do general fact-checking. So we look at misinformation from lots of different platforms. But initially, we started out looking at budget and public finance claims. And in the course of that, I think in the course of our general fact-checking, we've encountered quite a lot of health-related misinformation. And mine is also from my mom. I sent her the link. I hope she's watching. And it's that eating the seeds from fruits will make them grow in your stomach. So every time you get a stomachache, that's one of the seeds that's germinating. So every now and then I try not to eat the seeds from the fruits, but it feels like it's common. So probably, Dr. Amobi, you must have whispered into my mom's ear. You must have whispered into my mom's ear.
Yeah. Yes.
Yeah. It's interesting. All of these myths that we carry with us, we, ourselves, we're researchers, we're practitioners, we're following the latest science, we're trying to apply the latest science as we engage in fact checks, and yet we still engage in behaviors or practices that might be associated with health misinformation that our own organizations may have debunked. And I think that's a really important place to start this panel, is knowing that health misinformation, correcting health misinformation, and providing quality health information to the public is not an us and them dynamic. It's not as though we are kind of impervious to health myths and health beliefs. And starting at a place where we can all admit sort of the health misinformation or myths that we carry with us is a great place to start as a community. Next slide. So over the next hour, the panelists will share with us some of the overarching recommendations for effective health misinformation response. And that will be based on some of the empirical research that they've done, the lived experience that we've all had, and some of the lessons learned from projects in the past. Some of these recommendations include, as I've mentioned so far, and I think that this is a really important pillar to keep in mind, making sure that as researchers and practitioners in the fact-checking field, we ourselves are committed to reducing the stigma of asking questions around existing health beliefs. This is, of course, acknowledging that there are unintended and sometimes extremely problematic health outcomes associated with misinformation, but we do still want to encourage question and information-seeking behaviors. It also includes considering under-resourced health topics or populations underserved by traditional health systems, and making sure that the topics that we fact check are prioritized so that they're relevant to those audiences. And just a plug for our session next week, we have a health misinformation response workshop on the 30th, where participants will co-design a set of principles, expand upon these, sort of a code of ethics or a standard of care for how to respond to health misinformation in both the prolonged public health challenges as well as in crisis settings. Next slide. So we know at this point that health misinformation does impact health outcomes. Next. And And we're experiencing a historical moment today where the world has more internet users than people with access to essential health services, such as primary care or dental care or surgery. And over 80% of internet users at this point search for health-related topics online, which we know influences health decisions and behaviors and health outcomes for populations on scales larger than ever before. And at the same time, health misinformation is becoming an increasingly complex problem to address, especially given the spread and virality of misinformation online. Our digital information ecosystem can widen, and we know it can amplify fears of things like vaccinations, of diagnostic processes, of treatments, of interventions. And we know that the spread of this low credibility content can lead to distrust not only between health providers and their patients, but between communities and their health systems, and that this disproportionately affects populations in low socioeconomic environments and in queer communities and in communities of color. Next slide. I also do want to apologize for some of the background noises that you'll hear. As this is Mexico City, we do have a lot of cues, sound-based cues to know what we should be doing. This is our take out the garbage cowbell. So I hope that you're able to hear me over it. I'll just wait until they pass from directly under us. So in order to respond to health misinformation effectively, it's important to look to the history of how health misinformation responses came from the public health community itself. And while we know that the terminology to describe health misinformation now has become really nuanced and categorizations have helped with aligning response efforts to specific goals, which Olivia will share more about in her presentation. It's important to also look to the decades of public health literature that has tools and approaches and methodologies that might be able to strengthen health misinformation response efforts. So in the field of public health, some of the metrics of success for health promotion and communications are based on changes in attitudes and beliefs and perceptions of social norms. And these metrics can be used to serve stronger interventions. So I added some of the key terms here, so you might be able to review them in your literature searches for what framing the field of public health has towards health misinformation. Next slide. I've added here some of the challenges that the public health field and standards of care and public health response have identified that are associated with fact-checking health content and communicating about challenging health topics. So we know that accessing relevant expertise is a challenge, and Syed will talk a little bit about approaches for this in his presentation. We know that there are challenges with generalizability, with disclaimers and with caveats of fact checks. And we know that disclaimers are an important component of safety, for example, in fact checks surrounding vitamin supplementation, where certain vitamins may be accompanied by contraindications in treatments for conditions like HIV or cancer. And we know that there's a challenge with the representation of stigmatized health conditions. We know where there are limitations to health services, that it's important to prioritize fact checks of these under-resourced or stigmatized topics. Next slide. And with regards to preparedness, let's continue. Next slide. We know that not all health topics, whether prolonged health challenges like non-communicable diseases such as diabetes or an emergency context like the COVID-19 pandemic, require the same approaches and strategies. Next slide. So at Meedan's Digital Health Lab right now, we're working to provide resources directly to communicators, to fact checkers, to journalists, and to other community information leaders we're working with, such as religious leaders or youth ambassadors, knowing that you're the ones that know how to communicate to your audience is the best, and that as public health professionals, we really just want to be a resource. Next slide. So we have this epic global team right now of public health experts who offer summaries of the latest health research, who offer references to whether kind of research findings are generalizable to the audiences that you're serving, as well as curated resource lists for topics that fact checkers actually request from us. So for COVID-19, we've created an online localized database for all of the context that we've put together so far, and we're continuing to provide information on an as-needed basis based on the requests that we receive from fact checkers. So I'll be sure to share the link on the Google form on Slack, so if you're interested in requesting research summaries or resources from our health team, we can connect you directly. Next slide. And we know that there are many public health principles and behavior science best practices that can be applied in health misinformation response efforts that can kind of, when coupled with accessing the right experts and having accessible folks that you might be able to use as a resource in conducting your fact checks, that they can produce more efficacious responses. Next slide. So here I list a few of those best practices and strategies. In the more detailed slides that we share on Slack, you'll have access to a more detailed description of these, and Olivia will be touching on them a lot in her presentation. And they're also explained in more detail in the Health Equity Through Health Fact-Checking Primer that Meedan released last December, so we'll be sure to link to that as well. We also have a misinfodemics report that's coming out soon with 2 entries that have already been released, focusing on how countries around the world have responded to health misinformation, specifically in the early stages of the COVID-19 pandemic. So a link to that as well. Next slide. Thanks so much. This is a quick overview. We're excited for more content. We're excited that you're here. We're excited to learn with you. And we're definitely looking forward to finding new ways to collaborate together as we work to strive to reduce the impact of health misinformation. And without further ado, let's take us back to our gathering with all the panelists. Thank you all so much for being here. Everyone's contributing such a unique element to this project and to this panel and to the work that we're all doing. And without further ado, why don't we hear from our first panelist, Dr. Olivia Vicol.
Thank you, Nat, for that fantastic introduction and for historicizing health misinformation and its typologies. One thing I want to draw our attention to and follow from your point is that every typology in a way is a product of its time. So what I'm going to do now is introduce you to a typology I've been working on together with colleagues at Africa Check and Chequiado. For the past year, we have been working on a project funded by Illuminate, where we drew on research from psychology, anthropology, and health communication more recently to understand more about what the academic literature tells us about misinformation and how we can tackle it. And speaking of typologies, in the briefing I'm going to be basing this presentation on, I draw a distinction between 3 types of misinformation based on how they grip the public imagination, based on what they do to our psyche in a way. And the 3 are crises, conspiracies, and everyday biases. Today I'm going to be talking about the first 2. Next slide, please. All right, let's start with crises. And one more slide. Crises are characterized by disruption. They are those moments when the simplest everyday routines are plunged into uncertainty and we just don't know what's happening around our world. Now, they matter because uncertainty is a very stressful psychological state to be in. And this stress, this sense of uncertainty, then interacts with the public, our ability to process information, in 2 ways. So on one hand, people in crises, basically all of us at the moment, tend to look for more information. We want to make sense of what's happening around us and get some answers. But at the same time, paradoxically, under conditions of stress and uncertainty, we are less able to process complex information properly. And let's take an example. Next slide, please. In the UK, Ofcom, who is the regulator for the communications industry, started running a survey on the first week of the lockdown, which in the UK was around the end of March. Now, what they did was survey a sample representative of the British public, and they found this, that almost a quarter of respondents accessed the news 20 times a day or more. And 99%, pretty much every person they surveyed, accessed the news at least once. So we can see that at least at the beginning of the crisis, there is this flurry of activity. We need to make sense of what's happening around us. But there's a trick. Next slide, please. Even though Britons were so connected to the news, nearly 40% of them, at that time in week 1, reported finding it really hard to know what's true and false about COVID-19. So we read more, but we didn't quite understand so much. So when it comes to crises, the two recommendations we are making in the briefing are this. Next slide, please. First, it's use clear and simple messaging and design to recognize the fact that processing information gets harder under conditions of uncertainty. The next one is to repeat these messages consistently to account for the fact that people will read the news more frequently on more channels, and it's important to say the same thing in the same voice. So that's when it comes to crisis. I would say that the recommendations are quite simple, and I would love to hear your views on them. But things get a lot more complicated, and our possibilities for action as well change a lot when we refer to a different type of misinformation in a different moment. Next slide, please. Conspiracies. Please forgive the imagery. So when I talk about conspiracies, I am referring to a way of interpreting the world through filters of mistrust. Next slide, please. And suspicion. So what I would want us to remember is that conspiracy theories, and generally the tendency to believe in conspiracy theories, isn't just something that depends on your level of education, whether you went to school or not, or whether you're a man or a woman. It's a whole worldview. It's a way of understanding the world around you. And this matters for two reasons. First, it matters because it's extremely difficult to change the way in which someone perceives the entire world around them. And second, it matters because conspiracies can also spread from groups of convinced believers to the general public. And here we have a duty to prevent it, and we also have a bit more power to prevent it. Next slide, please. So the one conspiracy I would like to think about today is around vaccination. Now, the conspiracy here is that vaccines are not safe, that there's some undisclosed side effects, and they can give you diseases instead of preventing them, and no one's telling you about them. Now, according to the World Health Organization, vaccine hesitancy, which is what derives from the conspiracy, vaccine hesitancy is one of the top 10 health problems in the world. So what do we know about it? Next slide, please. A study with 5,000 individuals across a number of countries, I think it was 12 or 13 countries, found that vaccine hesitancy is associated with 3 factors. Remember, this is the language of psychology where we really try to simplify things and find associations, right? So on one hand, one predictor was participants' level of conspiratorial ideation. That's that worldview of mistrust. Now, the second association was with something psychologists call reactance, which is a tendency to reject being told what to do. And we have to remember that in most of the world, vaccines are mandatory. So for a segment of the population who simply cannot be told what to do, that can be irritating. The third, and I think most interesting association, a weaker association, but a significant one nonetheless, was between vaccine hesitancy and the fear of blood and needles. And it's remarkable if you think of how much pro-vaccination literature is illustrated with pictures of syringes and hypodermic needles, and that kind of imaginary that apparently, according to this one study, is off-putting for some people. Now, naturally, apart from psychological factors, hesitancy may also depend on pragmatic elements and on family elements and myths and so on. But what we know for sure is that regardless of the complexity of explanations, there are still many people in the world who don't perceive vaccines as being safe. And this is very serious. Next slide, please. Okay. The slide here, and I would like you all, if you can, to zoom out your screens. The slide here summarizes findings by the Wellcome Global Monitor, who ran a survey in 2018 on attitudes to vaccination around the world. Now, the blue segments on your screen represent the proportion of people who agreed to the idea that vaccines are safe. The gray ones represent the proportion of people who either had no opinion or disagreed. And I would like you to look to the bottom of the slide and realize how big the gap was in regions like Western Europe and Eastern Europe, where a significant proportion of the population were just not convinced that vaccines were safe. And it's quite remarkable if you think of the fact that these are regions which, relatively speaking, have good education and good health systems. Next slide, please. Sadly, the same hesitancy around vaccination occurs in the UK with regards to the coronavirus vaccine that hasn't even been produced yet. So I'm going to get us to think back of the UK communications regulator, Ofcom, who kept running the survey week after week and found that almost 1 in 5, 20% of respondents reported coming across claims about the potential dangers of a coronavirus vaccine. Now, this wasn't the only conspiracy theory that emerged during lockdown. As we know, there's a flurry of activity, there's a lot going on there. But the survey learned that when people did come across around other conspiracy theories, they were not just presented as something that was false and debunked, they were generally presented as something that was true. So next slide, please. So the survey designers acknowledged the fact that people may have heard a theory, but heard it in the context of a fact check that debunked it, not necessarily a post that supported it. So they went back to the public and they asked, thinking of all the times that you have come across this theory about the dangers of a coronavirus vaccine, about 5G and coronavirus, thinking back of all these times, did you hear it reported as true, false, or something you didn't know about? And if you can look at your screens, you'll find that in the case of the vaccine conspiracy, about equal numbers of people saw it reported as true and as false. With other theories, like the 5G, the majority of people had seen it being reported as false. Next slide, please. Right, so now that we know so much about the breadth of this issue and the reason why it matters, how can we actually correct it? Thank you for that slide. So in researching the health briefing, we reviewed 7 empirical studies which tested the effectiveness of debunks on vaccine hesitancy. And it's fair to say, first of all, that there is a lot of diversity in the type of debunk used. Some experiments used text-based materials, I guess what we would call a traditional fact check. Others used images and narratives, fear-inducing images, and so on. Most of them are based on one-off surveys. And unfortunately, a lot of the research remains focused on populations from the global north, including, notably the US. But with these caveats in mind, here's what we learned. So let's stay on this slide. I realized there's a lot to take in, but it makes sense, and I hope that it's a good resource for you after the presentation. So in the second column of the table, we gave you the reference to the study. You can always check it for yourselves. On the third column, we mentioned the sample size, how big it was, where it was selected from, and whether or not it was representative. In the column for the type of vaccine, we mentioned whether it's a real or fictitious vaccine, and you can see that a couple of examples were about that zombie claim that won't die, about the MMR vaccine and autism. Another couple of studies were about the flu vaccine. And finally, we looked at various types of treatments. So you'll notice that there's various rows for each study, because some of the studies used multiple interventions, just a text-based one or a picture-based one, or a fear-based one. Now, the most interesting part comes in the last 3 columns, the colorful ones. They refer to what really happened, to the outcomes of the intervention. And we learned this. The first column is about people's concerns with vaccine safety, things such as, do vaccines give you autism or not? The second is about concerns with side effects. And the final one is about intention to vaccinate. And we marked as green interventions where things generally got better, yellow where there was no statistically significant difference, and red where things actually got worse. And if you look at it overall, and I would like you to focus on the first 5 studies primarily, it's that challenging vaccine misinformation is an uphill battle, to say the least. When it comes to belief in vaccine safety, on one hand, we can see 3 green rectangles, studies that used text-based explanatory fact check style interventions found that yes, they made a positive difference on belief. On the other hand, they in belief in safety, in general safety, but they didn't really affect belief in vaccine side effects, and also actual behaviors, the intention to go and take the jab in practice, that was generally unaffected. And in a couple of studies, there was even a backfire for a very for a particular group of people who were already very skeptical. So I'm going to move us to the next slide on recommendations. There is a lot to process, and I do hope that this is a useful resource for you after the presentation. But in summary, I would say this. When it comes to anti-vaccination conspiracies, try not to give bad information more exposure and just focus on prevention, because we've seen how hard it is, first of all. Checking things on social media and marking them as false makes sense to the extent that it prevents more users from seeing it. But don't publicize those fact checks that widely, because there is a risk that in debunking every single myth about the vaccine, we bring these to the attention of people who wouldn't have seen them otherwise. So we're not saying let that misinformation live, but prevent it if you can, rather than making more of it. Also, avoid fear-inducing messages, because generally they have done more harm than good. Remember that many vaccine-hesitant individuals hate needles, at least according to this study. Your target is the general public, not vocal deniers, because as we know, conspiracy ideation is extremely difficult to correct. And please keep reading. Let's keep doing research, because we need it. There's a lot of variance out there and a lot of work to do, especially with effects on behaviors, especially with populations from the global south, and especially with the evolution of beliefs and behaviors through history. And I'm going to take us to the final slide, which is the next one after this. Oh, yes. So if you'd like to learn more from me on everyday biases, which is the third type in the typology, we're doing another workshop on Tuesday the 30th. And final slide, please. If you'd like to read the health misinformation briefing in depth and any of the other reports we've worked on together with partners at Africa Check and Chequeado, please do have a look on the website. And I thank you very much.
Awesome. How insightful was that? Thank you so much for distilling the academic research. That was an incredible, super insightful presentation. And then just to confirm, we'll be sharing those slides with participants on Slack. Is that right, Olivia?
Correct.
Awesome. Okay, perfect. And we'll transition now into a bit more academic research, continuing to follow up with Olivia's excellent points around conspiracy theories. Diving into them will be Dr. Amobi. Take it away.
Hi. Thank you, everyone. Nat and Olivia have brilliantly explained the concepts of misinformation and conspiracy theories. And Olivia has gone ahead to talk about the myths surrounding vaccinations. So I'm just going to go ahead and give examples of some common conspiracy theories and misinformation in the public domain in Nigeria. Then I'll share a few findings of my ongoing study on how people process misinformation and conspiracy theories through certain filters and intervening variables, and how the outcomes ultimately shape their responses to recommended safety measures. So can I have the first slide, please? Yeah, there are quite a lot of them, but I'm going to mention a few prevalent instances of misinformation surrounding COVID-19 in Nigeria. One of them is that steam inhalation is potent in prevention of the COVID-19. that coronavirus is inactive in tropical countries such as Nigeria, that African blood has immunity against the virus, and that if you make a drink of garlic, onions, lemon, pepper Geynes, or what we call uziza in Igbo, and Negro pepper, or what we call uda in Igbo, then use the siam weed, they all can cure the COVID-19. If you also boil pineapple peels, add lime and ginger, it can cure COVID-19. And then when you add a lot of pepper, there's something we call pepper soup, and take it, it can cure COVID-19. Next slide, please. So these are some of the misinformation that we have. And then we have, I have a few examples of conspiracy theories. Some of them, one of them is that coronavirus was manufactured in this Chinese laboratory. This is a global one. And in Nigeria here, there's a lot of suspicion because there are a lot of claims going around that the government, that coronavirus is a hoax created by government to get some benefits from developed countries, you know, get funding from international aid agencies. And so that much of the information they are offering about coronavirus is deceptive. And that the 5G technology is associated or causes COVID-19. As a matter of fact, there was a pastor who said that the government introduced a lockdown policy in Nigeria so as to keep people off the streets because they were laying cables for the 5G network. And there are cases that the cases reported by the NCDC is inflated so as to get funds from international agencies. Next slide, please. Some of these information are disseminated on various platforms, social media platforms like Facebook, WhatsApp, Instagram, Twitter, YouTube, but mostly on WhatsApp and Facebook or Instagram. Those are the three most popular platforms in Nigeria. They are also on online websites, you know, media outlets and blogs. And sorry, this is not the slide I want. Can you move it, please? Can you move the slide? No. I think I shuffled my slides. Please go down. No? I'm on sources, or perhaps you skipped it. Yes, that's where I am. And then, you know, then some on mainstream media, newspapers, radio, and television. Then the sources of this misinformation and conspiracy theories are, you know, religious leaders, celebrities, government officials, interpersonal networks, rumors, community beliefs, and traditional health practitioners. Because I think you have to go back to processing misinformation and conspiracy theories. Yes. So when people are exposed to these conspiracy theories and misinformation, what happens during the decoding process determines the believability or otherwise of the information. So there are filters or intervening variables through which information is usually decoded or processed. And some of these filters or intervening variables are one, basic needs, or what I say, which includes, people want to return to the status quo ante. There are basic needs that people have, which include, physiological needs, which includes food, water, sleep, sex, and all that. And then safety needs, security of life, employment, resources, family, health, property, love, belonging, friendship, family, and sexual intimacy. And so, when next slide, please. Yes. When Kaz and Bloma shifted the debate from what the media do to people to what people actively use the media for, they also shifted the focus to how people use media messages to gratify their various needs. And some of these I have listed, in the diagram. These needs are basic and fundamental to people's well-being. And when they are disrupted by environmental shocks, like hurricanes or health issues, like pandemic, like the pandemic we're currently experiencing, people's lives are upturned and they crave for a return to the status quo ante. So any new piece of information, even if false, that promises that restoration is easily preferred, believed, and embraced, even by people who should know better. So it's not surprising, therefore, that some of the misinformation and conspiracy theories are believed and shared by people who should know better. I will now share some of my research findings. Please can. Yeah, that's it. On on familiarity with misinformation, conspiracy theories, and their trust of government media. We can see from the slide here that public trust of government media, interpersonal networks, opinion leaders such as pastors and celebrities. Generally, I'll just summarize it. Generally, the public is familiar, they're very familiar with false claims circulating in the public domain. And they trust information from the media more than that from government. 44% of the respondents trust information from the mainstream media, and 26% trust information from government, while just 15% trust information from social media. Another intervening variable, cultural factors. Please, can you go up? I think you missed. Yeah, cultural factors. These are, and prejudices, cultural beliefs, prejudices are some of the factors that intervene in the decoding process. Some people believe in the efficacy of traditional interventions and attribute all disorders to supernatural forces. Some consider what their religious leaders say as sacrosanct, and these are sometimes elevated above their senses of reasoning. So I have this slide. Okay, where you are. This is a slide on familiarity. I have summarized it. Majority of the people are familiar with a lot of the misinformation and conspiracy theories in the public domain. Next slide, please. And same thing with okay. Now, the practice of containment of their responses to the government containment policies. Most of them were found to, in addition to being familiar with these misinformation and conspiracy theories, they were also familiar with government containment policies, and they actually practiced many of them. You can see on the slide that 69% of them say they go out for extremely necessary items. They do not visit family and friends, 56%. They practice physical and social distancing, 53% of them. They wear, 75% of them wear facial masks. 81% practice hand washing. 75% use hand sanitizer. 75% abstain from religious activities. 77% abstain from social activities. 70% do not use non-prescribed drugs for prevention. 56% do not use miracle remedies for prevention and cure. And 74% of them will submit to screening and isolation where necessary. So, they, when they were asked, can you hear me?
Yeah, thanks so much. Thanks so much, Dr. Amobi. I'm so sorry we need to pull to the other presentations just because we're nearing the end of our allotted time. So we just need to transition quickly over to Eric and then to Syed. Thank you so much so far, and hopefully we can address the rest of the presentation in the question period. Off to Eric.
Cool. Thanks, Nat. So the thing with health misinformation, as from my experience as fact checkers, is that it usually manifests similarly to how you'd see a disease manifesting, in that sometimes it's a symptom in itself of a broader condition of false information spreading, and some other times it's just self-contained, where there's a lack of credible information. So in the absence of this credible information, we find that the false information is creeping in. So like I mentioned, I work with Pesa, which is based in Kenya, and we look at claims about budgets and public finance. And with time, we've also started to look a lot more into how people interact with false information. Next slide. Okay, so the question that I'm trying to answer is, where do fact checkers fit in all of this? Now that Olivia and Nat have talked about how the false information is manifesting, and they've done a lot of studies. Next slide. So this is how we try to work with our general fact checking when it comes to looking at lots of different claims. We start with identifying the claim, we look at the data, we authenticate the data that we have that we try to use to verify the information, and then we use the credible information that we have gathered to verify the claim, and then we publish the findings. So this is the approach that we use in our general fact checking, and we also use it in our health-related fact checking, because it helps to sort of tackle the misinformation at its core. We identify what exactly is making the false information false, and then from there we try to look at any credible sources that we can quote, or anyone that we can cite when it comes to tackling the misinformation. Next slide. So I start with identifying the claim, and then we present the false claims in a way that doesn't amplify the falsehood. Because one of the things that we're trying to avoid is a situation where we're giving the false information another platform to manifest. And because of that, we try to distance the false information as much as possible from the fact checks. So for example, if it's a link, we try to take the link out of the situation where it is, we archive it, and then we put it in our fact check. And then also, we don't try to disparage the people who have fallen for this false information, because a lot of times this becomes like a point of hesitance for people to consume factual information where they feel like they're being targeted or they're being made fun of because they fell for a certain false claim. And then we also try to find the best possible evidence which stands up to the highest level of scrutiny. So we try to work with credible organizations, so trusted entities, if it's government, if it's or entities like the WHO, for example, and we try to use them as a starting point for our fact check. So we don't just say because this entity has said this is false, that means it's false. We add in our own research and our own findings so that we're able to balance our research with expert input. Next slide. So we also try to understand the anatomy of a false claim. How does it look? Sometimes it's an image, sometimes it's a video, and we try to compare and contrast it with similar claims, because you find that a lot of times, especially because we've been collaborating on the Coronavirus Facts Alliance, we've seen the same claims manifest in different languages and in different countries, and every time it might have a bit change to make it more locally relevant. And then how does a claim interact with the available evidence? We've seen claims try to preempt the fact check. So they say, if someone says something against this, or if someone tries to contradict this, it means they are fighting against the spread of credible information. Next slide. So fact checkers can work to fight health misinformation by finding the false information where it is and highlighting sources of factual information, and then also connecting audiences with subject matter experts. So by finding the false information, it involves a lot of research, trying to surface these claims, trying to find where the claims are and how they're manifesting, and then pointing audiences to the sources where they can get credible and verified information. So that the audiences don't have to always come to you whenever they see something false. So for example, we've seen fact-checking organizations produce tip sheets. We've also seen entities like the WHO publish claims that they've seen about the COVID-19, for example, and things like, does garlic work? Does the virus affect countries with high temperatures, and other claims like these. So if you do an online search of a false claim in this way, then you're able to see the evidence presented by any of these entities, and you're able to use this information to verify the information that you're consuming. Next slide. So identifying the platforms where the false information is circulating is essential in terms of diagnosing the spread where the false information has appeared and where it's being consumed. And then, why is it spreading? Is it speaking to something that's relevant to the people who are consuming it? And then the evidence, what does it look like? How does it need to be presented to make it more palatable and more easily consumed by audiences? Identifying potential actors behind the false information, which helps when it comes to interventions, like identifying people like anti-vaxxers, or people who are campaigning against vaccines, or people who are campaigning to attack 5G towers, saying they're responsible for the coronavirus, people like those. And then potential trends where this misinformation is likely to plug into already spreading false information. Next slide. And that's my time.
I'm so sorry about the cutoff time. So what we're going to have to do is in our session on Tuesday, the 30th next week, please join us so that we can ask any additional questions of these panelists. And I'll quickly transfer it over to Syed to round out our presentations.
Yeah, thank you so much, Nat. Let me quickly share a couple of thoughts, because I think we had fascinating insight with previous speakers about how medical misinformation spreads. What are the different factors which make it such a big challenge? I think one of the key issues is with the medical misinformation is a big challenge, to be honest, particularly with COVID-19 now, with millions of videos and pictures going all viral all the time across the world. Now, the challenge is how to combat it. And I don't think the combating misinformation, or for that matter, the medical misinformation, is only the job of journalists or the media for that matter. I think we need to have a collaboration with different stakeholders to make sure that we understand the nature of problem better, so that we can identify it better, and then we can combat it better. Next slide, please. And I think one of the, in India, what we have been doing since last 3-4 years essentially has been this partnership with doctors, because that is driven by this thought that we need to build deep collaboration with people who are not in journalism, but they have a different domain expertise. So, in our case, for example, we identified doctors, oncologists, mental health experts, public health experts, virologists. Next slide, please. And we had this group of doctors with us, and the whole journey started with a small, modest boot camp in 2015 in one part of India, in which we invited some 40 people, 20 journalists, and 20 doctors in one room. And we told them, okay, how are we going to work together? And to our surprise, the event started, the boot camp started at 9 o'clock. The room was half full, and it was all doctors. Journalists are still coming one by one. So that was again the learning for us, how different professions work with different commitments to time and all. So that boot camp eventually gave us some sense how we can work together in collaboration, particularly understanding the health better, public health better, using data and evidence, and eventually the fact checking. And then after that, we have done trainings across Asia, almost in now 13, 15 countries, in which we have trained almost 3,000 plus doctors. The next slide, please. Across Asia who are not part of us. Then last year, much before the COVID, actually, we thought like it's great to have people and have a conversation about issues. Can we just join hands and do kind of coordination and work together on day-to-day basis? And then we put up open call, inviting doctors all across Asia. Why don't you become our partners in fact checking? And we got some 100 plus applications. After them, we selected those you can see on the screen, and now they have expertise in different areas of health, and they work with our editorial team on day-to-day basis. They write articles, they help to understand different issues related to health, particularly now with the COVID. And I think somewhere down the line, it was a great experience for us that we can come back and identify medical misinformation with the help of domain experts. We as a journalist are a good communicators, we can write well, but the doctors have a domain expertise, they have a knowledge of different areas of medicine, public health. They can explain the context to us better, and they can explain the issues to us better. Next slide, please. So that's how our whole, we call it First Check, which is a dedicated medical misinformation fact-checking website in India, working across Asia. I think there have been 3 issues with us, essentially, learning how to build collaboration, essentially. It's like, what are the key challenges when you do collaboration with non-journalists? What are the opportunities when you build collaboration with non-journalists? And we found many collaboration opportunities, to be honest. And next slide, please. And we also saw what are the pitfalls of collaboration. And then that's also very important, to be honest, because when you build collaboration, it means putting more effort into the collaboration. It also means that the team on the both sides need to be essentially and completely clear about the aims and objectives of this collaboration. It should not be like a headless chicken situation where people do not know why they're collaborating with each other. So we knew exactly what we want from them. We gave them a proper letter that if you want to be fact check specialist with us, these are the 3 things we need from you. Like, we need 1 or 2 hours every month. We need you to write often on different situations. So kind of a clear understanding why we are doing this collaboration. And I think it's also important to find right people at right time. That's really fundamentally very important in terms of science and medical fact checking. And I think eventually, if I conclude with the one thought, I think that has been, we have to really think of how to converge different domain expertise into journalism, into fact checking. Right now, what's happening is essentially a lot of journalists doing a lot of fact checking all the time, but I think there are a lot of other people who have very critical expertise and capacities, like data scientists, technologists, and doctors, who can lift and scale the medical fact checking across the world. Yeah, so with those thoughts, I think we can take a couple of questions, and back to Nat again.
Perfect. Thank you so much, Syed. And for those, sorry, apologies also for the puppy that makes it into the screen every so often. But for those who are just learning about DataLEADS' incredible health misinformation response work right now, it's one of the most amazing projects in directly embedding health providers into existing projects and existing fact-checking efforts. So I might turn this over to Olivia to reference the first question that was asked to us around giving bad information more exposure.
Correct. That's the $1 million question. So the exact question was from Tanu Mitra. Thank you very much for that. How do we make sure that we don't give bad information more exposure? And I would say this. If we're talking about the claim that has already received a lot of exposure, for instance, it's a claim that comes from a person in a position of power, it's already in the national media, then people likely already know. Do fact check that. Do give people the truth. What I would suggest, what I recommend that you don't do is take something from an obscure social media group and broadcast it to the rest of the world. So if it's already in the public domain and people know about it, by all means, fact check it, and by all means, be firm about the fact that it's false.
Awesome. For the second question from Inga Springe, I'd like to turn this over to Eric, if you're interested in responding, specifically around Olivia's mention of people being afraid of needles and blood. So there's more dislike towards those types of visuals, and those tend to be used in public health communications. What sort of visuals do you tend to show when you're developing fact checks?
So we try to communicate as much as possible what the core of the claim is. So if it's something that's related to vaccines, we try to take the needle out of the equation and then focus on the vial. And if it's something that, so we don't want to trigger people. And a lot of times we find ourselves having to balance between sharing the exact visuals that have been shared and trying to develop our own sort of visuals. So we have a standard set of banners that we use when you're communicating on our fact checks. This is true, this is false. So the main aim that we're trying to communicate is a verdict, or the main thing that we're trying to communicate is the headline, which states what the claim is, and then the banner image, which talks about the verdict. So we try to leave the visuals out of it as much as possible, anything that can be triggering.
That's a really great point. We don't often think about this, especially if content is triggering, if it's not a myth that we're directly affected by. So that's a really great point. I wanted to ask you, Dr. Amobi, we have one question from Pratyush Ranjan from India. It was originally asked of Eric, but I think it would be great to hear from both of you. Dr. Amobi, if you can respond first, what's the biggest hurdle that you face in debunking health misinfodemics in your region?
In debunking what?
Health misinformation or misinfodemics in Nigeria.
The greatest hurdle?
Yeah, the greatest hurdle.
Well, like I mentioned, I talked about cultural beliefs. A lot of people have a mindset. They already believe in certain things. They believe in, for instance, they attribute health disorders to supernatural forces and all that. And so when you have health misinformation that comes out, regarding in that regards, you find it difficult to explain to them that it is not correct, because another one is the belief in, for instance, religious leaders, and all that, whatever their religious leaders say is sacrosanct. And so you find it difficult convincing them otherwise when certain information is coming from them. Then you have the belief in taking traditional herbal miracle medicines. We have a lot of traditional health practitioners who are actually the sources of some of this misinformation. And you find there are people who believe that, once they are ill, they believe in something that they call it taboo, particularly people from the southwest of Nigeria. So for all ailments, they have taboo that they take for every ailment possible. And you find that, when there are misinformation about health, whatever you tell them, they don't believe. They believe that taboo can cure all those ailments. So that is one of the biggest hurdles that we have in debunking health misinformation.
Yeah, absolutely. And I think one point you highlighted in your presentation around the misinformation that sort of fills the gaps, the misinformation, that, you know, when people are desiring to get back to a status quo in an emergency context.
That's another thing. You know, when there are, when there is an upset in the environmental upset, there is a disequilibrium, and people, their lives are upturned overnight. Their lives have changed, and so there is a desire for them to return to the status quo ante, and so they are looking at any information, whether it's false or true, as long as it speaks to their needs to return to the status quo, will easily be embraced by them. And you find that even sometimes this information defies logic, and you would expect that people who should know better will know that this is wrong. But because it resonates with their needs to return to normalcy, they will more easily embrace those information.
Yeah,
so that's
exactly.
part of the that's part of the problem. Cultural factors. The belief in their wish to return to status quo ante.
Awesome. Yeah, absolutely. Thanks so much. I think we might have time for a couple more questions. I wanted to share one question from Michelle Jennis, a medical student. Do you think, Syed specifically, that there is a future role for students, including medical students or journalism students or others, in tackling health misinformation?
No, I think certainly a huge future. Certainly a huge future. If you look at every global health organization, starting from WHO, there are certain key leadership positions which are not actually right now being filled because there are no people, capable people to fill those places. And I think in every country, because eventually the health is based on information. So whatever decision you take about healthcare has to be based on information. And I think there's already agreement in a lot of medical colleges, in preventive medicine for that matter, that they need doctors to be able to communicate better, to write policy papers better, and to speak better, and to fact check. And now, given COVID has given us new understanding how bad situation can be in terms of communication, I certainly see a huge role already in medical communication for that matter, or scientific communication for that matter. Or I can see bioinformatics people with those backgrounds, or preventive medicine people with those backgrounds, can have a really critical positions in the future leadership positions in different organizations.
Awesome. I think with that, we don't have any additional questions. I'd love to close out and give each one of our panelists just another quick thought, another quick important takeaway for the audience. Let's start with Eric, and then Dr. Amobi, and then Syed, and then Olivia.
Okay, so a lot of times fact checkers find themselves in positions where they have to check information in which they're not subject matter experts, and health is very personal because the consequences of health misinformation can be very damaging. And because of this, we try to get fact checkers to look at the evidence with a critical eye. So they need to approach it understanding that this isn't just any other false information. It has very tough and very real consequences for the people consuming it. So it's important to keep in mind that the evidence needs to be put on a pedestal, and it needs to be given as much visibility as possible when we're doing the fact checks. And then at the end of it, we also need to remember that these are human lives that we're dealing with. So we need to make sure that the fact checking work that we're doing keeps that in mind, so that at the end of it, we have a way forward that helps people fight this false information for themselves. Thanks.
Thank you so much, Eric, and hugely important point. Dr. Amobi, anything to leave the audience with?
Yeah, we have really talked about a lot of things, but in addition to this fact checking and what Syed talked about, all hands being on deck, everybody, it has to be a collaborative effort to fight misinformation. Remember, we talked about conversations that we're having around, about how to debunk some of these misinformation and conspiracy theories. And I believe that we should have them at every level, at the micro level, that is at the family level. There should be discussions, surrounding it, at a meso level, we talk, including them in school curriculum, at community level, sensitizing people about how. I think Africa Check is doing a great job, because Africa Check is running, there's a podcast they have, and they are doing some sensitization programs on radio and all that, to tell people how to verify information before you believe, you believe them to be true. And then the larger society, I think government has a role to play as well, in addition to mainstream media, which has been collaborating with social media. So I think it has to be at every level, the micro, meso, and the macro levels,
Absolutely.
That's
Thank you so much, Dr. Amobi. Syed, any closing remarks for us?
I think the misinformation is a huge challenge, and it's for the next 10 years is going to be actually the worst, given the how millions of people are coming on our internet for the first time in different parts of the world. So they're producing a lot of information all the time. So I don't think the journalists will be ever able to defeat and combat the tide of misinformation. You need to have a support of technologists, different domain experts. In this case, they can be doctors. In other way, they can be lawyers or engineers. A lot of different people with different expertise. And there should be an attempt made at different levels to learn from each other, collaborate from each other, and do not try to reinvent the wheel when somebody has already done some work. You don't need to learn medicine or do an MBBS degree to come to a medical fact checking. You can just ask a doctor. I think there's a great learning in collaboration, actually.
Exactly. And thanks for setting the stage for hopefully future collaborations around health misinformation amongst our participants and listeners. Olivia?
Thank you very much. I want to follow on precisely from what Syed said and end on an optimistic note. Yes, there are monster claims that keep coming back, and anti-vaccination is one of them. But there is a lot we can do, either in collaborating with experts and raising awareness at that top level, as we've heard, but also in investing in the proverbial media literacy initiative. We know that this works. We actually have a briefing on just media literacy interventions. We know that they can work with adults through the medium of online games. They also work with children in class. So I want to just end on this note that, yes, we can still do something about it in media literacy and in researching more, because this is a new and fabulously interesting field that's constantly developing.
Yeah, absolutely. And here in this panel was just one expression of what it looks like to have academic researchers, journalists, fact checkers, all kind of come together and try to tackle one really large but common issue. Collaboration is definitely the answer, and we welcome further discussion on Slack, via email, and any way that you're able to reach us. We're welcome and open and ready and excited to have these conversations about collaboration with you. Thank you, everybody, for joining in. We'll do a team wave. Bye, everyone.
Thank you so much. Thanks
Thank you for joining us.
Thanks a lot.
And what about the workshops?